Thank you very much for having me. It's really a pleasure to be here. So I'll be presenting on frailty and spinal conditions. Here are my disclosures, all related to research. I'll give you a brief overview. So spine is made up of concentric layers of bone all the way from the skull down to the tailbone. 31 concentric layers. You have 7 cervical vertebrae that connects to 12 thoracic, each with paired ribs all the way around, and then 5 lumbar, and then a few sacrum. And the sacrum is like a keystone that sits in the ring of the pelvis. And in the middle of it, you have here the spinal cord roots that come out, basically like a tree of a trunk, and then roots that come out that give your function to your arms and your legs and so forth. Tumors and traumatic conditions mostly affect the vertebral bodies here, and vertebral compression fractures, when they occur, can press on the nerves on the side or on the spinal cord. When they press on a nerve, they can cause weakness in what that nerve innervates, so to the hand or to the legs. When it hits on the spine here, let's say in the cervical spine, it'll cause injury to whatever is lower. So a tumor that eats away at the bone in the cervical spine can cause progressive weakness in the arms and leg function. And then you have these jelly-like discs, intervertebral discs in between each layer that are basically shock absorbers. They degenerate over time and lose water. So I'm going to talk a little bit about primary tumors. There are 2 types of tumors in the spine. There's primary tumors and metastatic tumors. Metastatic is somebody has breast cancer, prostate cancer, a tumor of some other site. It jumps to the spine through systemic disease, and you have a spinal lesion, often accompanied with lesions in the liver or visceral organs, femur. That's different than primary tumors. Primary tumors begin in the spine, and because of that, the indications for surgery and really the goals of treatment are different. And so for metastatic disease, it's purely palliative. You want to, if there's, these are patients that will often come in with pain, with weakness if there's cord compression and nerve compression, and you want to decompress that, you want to stabilize them and give them a better quality of life. A primary lesion, if there's no systemic disease, can be curative, and because of that, you want to take the tumor out all in one piece. And so the surgery is a bit different too than metastatic disease. So if this mic is a metastatic tumor, you might cut it away little by little and decompress the nerve or decompress the spinal cord. If this is a primary tumor, you're taking the whole podium. And so you want an en bloc resection, which means the tumor all in one piece with a normal tissue capsule around it. And just by the metaphor I use, you can see that that's really a much more involved surgery, a much more significant surgery. And that's really where frailty and patient selection comes into consideration. And so this is a paper that we published in World Neurosurgery last year looking at frailty indices and sort of risk stratification for patients with primary spinal tumors. And here are some examples of primary spinal tumors. So I wanted to, picture speaks 1,000 words, and I wanted to give you an idea of what these surgeries can kind of look like for primary spinal tumors. So here are normal surgical windows for cervical spine pathologies. And this is a patient with a high cervical chordoma, which is a primary spinal tumor that grows from the embryological notochord. It's too large, spanning from about C2 to C4. This is the tongue here for orientation, the brainstem right there, cerebellum, patient's facing that way to the left. It's too large for any one of these approaches, so really what needs to be done is a transmandibular approach where the jaw is split. And this is some fantastic illustration from our institution. And so the jaw is split, the pharynx is breached in there, moving the tongue to the side. And then you can see in the back there with the nerves to the facial expression and to the tongue preserved, and then the carotid, the jugular here dissected, the esophagus and trachea moved to the side. You can see the high cervical segments up here. And really, that's the only approach to get to that bony segment, to that tumor, and take it out en bloc. And then what needs to be done is, you see the spinal cord back here, because all that bone that was basically connecting the skull to the spine is removed. All those neck segments are removed, and so it needs a really significant reconstruction. This is in the thoracic spine. In the high thoracic spine, often you need cardiothoracic surgeons to help with the exposure and split the breastbone. Lower down, you may have to cut the ribs out and take this entire tumor in one piece, leaving bone on top, bone below, and then a spinal cord, also requiring some significant reconstruction in the front and in the back. And then this is a scoring system for sacral chordomas, which was also pioneered at our institution. This is a patient with a large sacral chordoma pushing on the rectum. These patients will often come in with these large lesions because they're not, unlike the brainstem where you may lose function of chewing, swallowing. In lower sacral segments, really people don't notice it until they're becoming incontinent and losing bowel bladder function. So these grow quite large, and the treatment for them is a complete sacral amputation, so dissociating the lumbar spine from the pelvis and then requiring significant reconstruction. And so the reason I go into all of that is that you can see that these surgeries are really very involved. And so what we wanted to do is develop a preoperative frailty index and aid in risk stratification for patients undergoing this surgery. So we did a univariate and a multivariate analysis of about 50 different factors, and 9 came up that were each significantly associated with in-hospital morbidity and length of hospital stay. And these are outlined here. And we gave each of these 1 point, and if a patient had 0 preoperatively, they were not frail. If they had 1 mildly frail, 2 moderate, and 3 severely frail or more. These were complications that were associated in a retrospective cohort of about 1,500 patients. And what we found was that the overall complication rate was about 10%, and the odds ratio was significant between groups of frailty. So between not frail, mildly frail, moderately, and severely frail, they had an increased odds ratio of having some kind of complication during their postoperative hospital stay. And the same was seen for hospital postoperative length of stay. So the more frail they were preoperatively, the more their length of stay was. And so in conclusion, for that part, the frail patients had significantly increased odds of developing postoperative complications, and risk stratification really can help patients, patient selection, surgical indications for patients that maybe are not able to tolerate such a massive procedure. And so we're going to just switch gears for the second half. We spoke a little bit about the spinal oncology. Trauma is also a huge factor in these patients, especially with an aging population with comorbidities and osteoporosis and low bone density. And that often affects the thoracic and the thoracolumbar spine. And so if we go back here, it's sort of a biomechanical issue. If we go back to where I showed the anatomy a bit, so here you have a thoracic segment which is pretty rigid, held in place by ribs, and then you have a lumbar segment below, which is very mobile, which really accounts for all of your flexion extension of the torso. And in the middle of the S, you have an apex here, which is under a high stress. And so elder patients with frailty and low bone density will often have fractures in that region, that thoracolumbar apex region, because of the high axial and shear force stresses present. And so what we wanted to do was also look at the frailty of patients in this geriatric population that have thoracic and thoracolumbar spinal tumors. And that's been demonstrated in other studies, but really hasn't been done before for frail patients. So we published this in Clinical Neurology and Neuroscience about a month ago. We used the ACS, the American College of Surgeons National database, and we looked at patients who underwent decompression or fusion or some kind of decompression and fixative procedure for thoracic and thoracolumbar spinal fractures. We used that database and a previously published, well-cited frailty indice score to stratify these patients and score them. And we found that patients, that 62% of the cohort underwent surgery as we expected. 38% had some kind of cement augmentation where a needle is injected into the vertebral body to stabilize that segment. And frail patients had a significantly larger 30-day mortality rate compared to the non-frail group. And that was 16.7 compared to 0.6%. And so, in conclusion, frailty and surgical intervention correlate with a higher 30-day complication rate for patients with thoracic and thoracolumbar fractures, and they also correlates with a higher 30-day mortality. And so, both frailties is important in the decision-making for spinal oncology and for traumatic injury for the aging population. Thank you, and that's my email if anybody has any questions afterwards.
Questions, probably. I have one. So, if you've got a patient who's got a large primary and shows up as at greater risk on the frailty index, so what's the decision there?
Has a large primary spinal tumor or primary elsewhere?
Primary spinal tumor.
Okay.
Or primary tumor impinging on spine, and also shows up at greatly elevated risk because of frailty factors.
Yeah.
What's the decision tree there?
So it depends on how they present, what the neurologic function is, what the extent of surgery would be. I mean, I think that these scores and sort of our work has helping to risk stratify patients, but it also depends on a patient-by-patient standpoint. It depends on where the lesion is located, what the adjacent structures are, and how much function you would need to take from the patient, and what the surgical morbidity would be. If it was a small primary lesion and the patient was not as frail, they might tolerate it better. If it was a large lesion and they were an already older population and their prognosis wasn't as good, you might turn a curative procedure into maybe a more palliative indication for that patient. So it goes into the decision making.
Thank you.
If that answers the question.
It does.
Yeah.
Thanks very much.
Thank you so much. Appreciate it.
There we go.
Hi, Liz Sciubba with Kaiser Health News. I'm interested in how you communicate these risks to patients, because in reporting on people with metastatic cancer, often they or their families will say, we want to do everything possible. Do you show them those illustrations? That might talk me out of it. I'm just wondering, I'm just wondering how do you, I've written about different ways to communicate surgical risks to patients. How do you do that?
So a lot of the time, as you would imagine, the illustrations, they're published and they're available, but they're not really shown as part of the consent process usually. But it's more a function, what the patient will be left with. So with those large sacral lesions, really S2 to 4 is responsible for bowel bladder. And if you want to give that patient a cure or a chance of a cure and the tumor's wrapped around the whole thing, you might discuss with them, well, by the way, you will take a longer time to get up. You will be, the massive reconstruction, you may be in PT for a while, and you'll lose all bowel bladder function. And so it really depends, again, we were saying what the adjacent structures are, what the indication for surgery, and then, patients, it's a shared decision. And so options are offered to patients, and a lot of patients will say, I want to be completely cured of this. I don't want to worry about this. I'm okay with having a little bit of a foot drop or bowel bladder issue. And some patients will say, no, maybe if you can just leave a little rim around that nerve and preserve that nerve, and I'm okay with taking the radiation and the chance for local recurrence. And so it's a shared decision making, and really the options are offered in the sense of what's the surgical morbidity and what's the function and what's the chance of the cure. And so it's really a balance between the risk and benefit that's shared between the decision making, and the best you can offer patients is to be honest about what the morbidity of both options are.
One last question.
How fixed is position on your frailty index? Is there rarely a chance for a prehab, if you will, to modify their risks from the surgery?
Yeah, it's a really great question. Because of the data that we did was from national inpatient samples, a lot of it is limited in looking at those kinds of variables. They do collect the preoperative electrolyte and preoperative prealbumin and different serum markers, which might be affected if patients have a long course of prehab. But it wasn't one of the factors that were in our. But your point is well received.
Thanks very much, Ali.
Thanks.
Terrific.
Appreciate it.
Great job.